I'm going to present to you the histopathology of pheochromocytoma, looking at the gross and then the microscopic features. And I will also include the immunohistochemistry, and you will see the reasons why I have put them there. So grossly, the specimen may come into the lab as either part of a radical nephrectomy, God forbid, but otherwise it will come in as an excision done because of an adrenal tumor. Sometimes needle biopsy will be sent in, but rarely. And as a word of caution, the fine needle aspiration is contraindicated in such cases. So I do not expect to see FNA specimens of pheo coming to my desk because of the obvious reasons. So grossly, I'll be talking about the sporadic pheochromocytomas, looking at them with the naked eye before I go to the super lenses on the scope. They will be seen as unilateral. I presuppose you will have given that to me on the request form. They will be solitary, unicentric, but of course I will also recognize that they are sharply circumscribed or almost encapsulated, firm in consistency, grayish to red or hemorrhagic in color. Even pathologists have feelings, so we feel the specimen and we also appreciate it. I also appreciate the changes of necrosis. I heard the radiologists also appreciate necrosis. So I also see that there are necrotic changes. There may be fibrosis or even cystic formation grossly. And we also have instruments to measure in pathology. We take measurements, I will measure, and usually they are more than 4 centimeters in diameter. And they usually weigh on an average of 90 grams. So literally that is an example I would give you, that we have a large adrenal neoplasm that has been sectioned into a half, and the tumor is noted to be arising from the medulla, if you remember the anatomy of your adrenal gland well. And I've indicated the tumor by that double-headed black arrow, which should be very clear. It is gray in color. I know we are, in pathology we always swing between two colors, gray and red. Rarely do we see other colors, but sometimes we see a bit of yellow. So, and there we can note that what appears as yellow is the remnant of adrenal cortex. And I've indicated that again by the yellow arrow. And there is still a bit of remnant of normal adrenal shown in blue. And these colors, as a disclaimer, have no bearing to the politics present. So from the gross, we move into the microscopy. And as pathologists, we always move in steps. We prefer to move from the lower magnification. As a pathologist, if you skip this, you're bound to land in danger, because the higher the pathologist climbs on the microscope, the more naked he's exposed. It becomes very confusing the higher you go. So we prefer to always start at the low power, which is the low magnification. And what we normally see in pheos is that the cells, the tumor cells, which are the chromaffin cells, are arranged in any of the architectural patterns that I have outlined there. They may appear as anastomosing cords of cells in line, like they are following a path somewhere, and we call that a trabecular pattern, just like the way hepatocytes arrange themselves. Or they may be alveolar patterns, or what others are calling the nested patterns, which are the Zell-Ballen features. In some cases, you may see a diffuse or a solid pattern, just see tumor cells forming sheets. But as, again, caution is that sometimes also a spindle cell pattern is present. And now all these patterns are set in a very rich vascular network. And I should be able to appreciate that on the low magnification. And good luck on your side, you may see a few scattered other neuronal or ganglion cells. And then once you've seen that on the low magnification, you want to climb just a little bit higher but not expose your nakedness. The individual tumor cells are usually polygonal or polyhedral in shape. They will have a lightly eosinophilic cytoplasm. When I say eosinophilic, I mean pink. And they will have a granular quality to it. The cytoplasm has that granular quality to it. It looks like it's seeded with, in form of like salt pellets. Sometimes, from literature that I read, is that you may chance on intracytoplasmic hyaline globules. They also again appear pink, but very distinct. And these cells, funny enough, have very indistinct cell borders. You may find difficult telling the difference between one cell from its neighbor. So all you see is just haphazardly organized, haphazardly spread out nuclei with their nuclei, but you can't tell where each cell is from its neighbor. And sometimes you will see scary features like pleomorphism. And you know, when a pathologist talks about pleomorphism, the next statement will be malignancy. But however, Pheo breaks the law. Sometimes you may see enlarged hyperchromatic nuclei. And again, as a word of caution here, is that these features do not equate to malignancy as far as Pheo is concerned. I will give you what defines malignancy in Pheo towards the end. So what we see here is a hematoxylin and eosin stained section of a pheochromocytoma. You barely can tell the distinct cell borders. All you see are those round bodies which are nuclei of the tumor cells with their well-formed pinpoint nucleoli which are within the nuclei. You can't tell the border between this cell and the next that is somewhere here. And then there is that rich vascular network. All that is a vascular network. Now this section again is hematoxylin and eosin stained. And what you see is this pattern of balling. You can see those balls of tumor cells. And again you see the vessels in there. Likewise, again, this is also hematoxylin and eosin stained. And you see the tumor cells, you see the pink cytoplasm, it has granularity in it, the central nuclei, and their nucleoli. So having looked at that, the pathologist usually gets confused because normally these specimens are not coming with enough clinical info. So what does the pathologist say? He puts down a comment line. Oh, this could be a corticocarcinoma. It could be a renal cell carcinoma. It could be a hepatocellular carcinoma or a metastatic carcinoma. And then usually sends back to the surgeon. But like my old professor used to say, pathologists are not magicians. They require to be supplied with history. We don't work under trees. So then you send back now with a more concise history, lab findings, and then now I can nail it down and tell you, oh, in view of this, what we are saying was actually a pheochromocytoma. In case you do not send this, or in case we can afford, remembering the embryology of the adrenal gland, remember that the medulla originates from the neurocrest. So those cells will always destine themselves to the neuroendocrine lineage. And modern science has availed immunohistochemistry to us, that we can trace where these cells are coming from. So we use some of these stains in immunohistochemistry to finally nail the case, the neuron-specific enolase. Wherever you see the golden brown color, that is positive. So I will say that this is strongly positive. Likewise, also chromogranin is also strongly positive. Synaptophysin is weakly positive. You do not see a lot of the golden brown coloring. And then when you throw an S100 to it, it will not stain the tumor cells, but what it does is to come and stain those sustentacular cells, the ganglion cells that I was talking about, that are usually in the background embracing the tumor cells. So in conclusion, the pheochromocytoma is a benign tumor. It is producing lots of catecholamines, and chemical pathology will probably have given us also a diagnosis through the VMA. Malignancy in the pheo is defined by the presence of metastases, and these are commonly in either the liver, the lymph nodes, the lungs, and the bones. Thank you for listening.